Welcome to Successful Return to Work for Cancer Survivors. What is the research telling us to do? Thank you for joining us today. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is part of our Harnessing Talent Alliance series. Harnessing Talent Alliance for Recruiting and Retaining Canadians with Disabilities is a 3-year project funded by Employment and Social Development Canada. We would like to thank our 9 founding partner organizations, especially Cancer and Work, represented by today's speakers, Dr. Christine Maheu and Maureen Parkinson, as well as our academic team. If you'd like to learn more, please visit us at harnessingtalentalliance.ca and follow us through our Harnessing Talent social media channels. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. We're very excited to welcome Dr. Christine Maheu and Maureen Parkinson today. Christine Maheu is an associate professor at the Ingram School of Nursing at McGill University. She's also a researcher at the McGill University Health Center and co-director and research lead for Cancer and Work. Maureen is the Provincial Vocational Rehabilitation Counselor at the BC Cancer Agency and co-director and content lead for Cancer and Work. So without further ado, I will hand it over to you.
Well, thank you for inviting us to give this talk on the successful return to work of cancer survivors. What is the research telling us to do? And thank you to those who are online. In this session, we will cover research-informed tips for cancer survivors and healthcare providers and employers that can be implemented to foster a successful return to work of cancer survivors. We will look at what standards for practice have been developed to date that can guide a return to work for cancer survivors. And we'll also present some overview of the parts of the Canadian bilingual Cancer and Work website that have been developed based on research.
So before we jump in, I'd like to just introduce you to the Cancer and Work website. How is this helpful for you? Well, the Cancer and Work website aims to guide cancer survivors, healthcare providers, employers, employer representatives to support cancer survivors with staying, returning, and finding work. The website has been formed when it was initially developed by 250 stakeholders who prioritize the information featured on the website. The website also integrates information from the research and follows best practice for vocational rehab and links to the best online resources available across the globe. Next.
Got me? Oops.
Yep.
Yeah. Wait. Okay, here we go. So in terms of the relevance of the cancer rehabilitation, we know that cancer has turned into a life-threatening chronic condition that for a large portion of patients that poses new challenges and the need to create a comprehensive care rehabilitation program. And while cancer is the disease most likely to occur in the older population, there's a significant number of individuals who will experience a cancer diagnosis at an age where career and work-related issues play an important role. There is a report by the Canadian Partnership Against Cancer, CPAC, that identifies that by 2031, there will be 2.2 million Canadians living with cancer, and that during their lifetime, nearly 1 in 2 Canadians will be diagnosed with cancer, and more than half will report difficulty with return to work and staying at work. There's approximately 40% of cancer survivors that are between the ages of 20 and 65, an age where of working population. There's an increased recognition that of the employment and work consequences following cancer treatment. And to this, many cancer survivors are also struggling with sustaining work once back at work. There's a systematic review exploring the ongoing physical and psychosocial problems of cancer survivors that report that 1 in 5 will experience cancer-related disabilities affecting their work abilities. And there's also a study that shows that cancer survivors are 1.4 more likely to be unemployed than their healthy controls, so resulting in a significant economic burden and affecting quality of life. A systematic review by Menard identified that while 63% of working age individuals will return to work within the first year of diagnosis or will continue working during treatment, There is between 26 to 53% of cancer survivors who will lose their job or quit working during or after treatment. And there's a study by Steiner looking at the impact physically and psychologically on work after cancer that found that while 92 out of their 100 cancer survivors surveyed did return to work, that 57% of them had reduced their work hours by 4 hours per week 2 years after the diagnosis.
So before we jump in, and as a framework for jumping in terms of talking about the research, and there are many research models to explain factors that influence return to work, workability, and employment for cancer survivors. We're using the one we developed for cancer and work, which has just been published in the Canadian Oncology Nursing Journal in December. This model gives more attention to psychological and systems factors that might influence and have emphasis on those models, or have more emphasis on this than other models. We'll try not to spend too much time here because it's very extensive sort of area, could be a presentation in itself. But at the end of the presentation, we have listed 3 comprehensive reviews that you could refer to if you wanted to look at many of the factors that influence working.
So to go a little bit, to look at a little bit in terms of the factors in terms of this vocational rehabilitation model, we see that having pre-existing condition for the cancer survivors can result in a worse return to work outcome. Whereas on the other hand, having a fair general health status and absence of comorbid chronic illnesses before the diagnosis can facilitate a return to work. For the disease and treatment type, we know that individuals with certain cancer diagnoses have faster return to work rates, such as with prostate and breast cancer, whereas lower rate have been noted with gastrointestinal cancers, lung cancers, head and neck, and a few others. In terms of treatment specific, we see that compared to surgery alone, a number of studies have reported that chemotherapy and multimodal treatment with mastectomy was associated with delayed return to work. The next influence is prognosis of the condition, such as the recovery following cancer, the stability of the illness, and experiencing many side effects of treatment, and if they're temporary or permanent, can result in a delayed return to work, or can result in early retirement. We also see that those who have lower predicted survival rate of less than 2 years have higher rate of stopping work. For the illness representation and perceived workability, we know that these are important influential factors that influences the return to work. And the Leventhal model of illness representation present that it can exert much influence on people's way of coping when dealing with perceived workability, which then can also influence their functional, physical, cognitive, and emotional outcomes. And there's a CPAC report from 2012 that says that among the cancer survivors who perceived that having diminished physical and mental capacity, they had more difficulty with finding work. Whereas cancer survivors who found that they had less fatigue, less depression, actually reported an increase in work functioning. So we know in terms of the person-related factors that demographic can also play a role, where we see for gender and age and education, they play a role in the influence of returning to work. Taminga found that there was an adverse effect on work with increase of age, and increased age was also associated with early retirement, and lower education was also resulting in less likely returning to work. Whereas obviously higher education was associated with a more successful return to work. When men also take sick days, they tend to take it for less, but when they do, when they do take sick days, they tend to take it longer than women. The meaning of work, including change of priorities. So here Marino showed that having higher adverse effect for those who saw work as less important. And in a study by Stewart found that 41% had a change in priorities with respect to work and 25% changed jobs. With the expectation of recovery, empirical studies here have indicated that the importance of patients' expectation of their recovery is a good predictor of their return to work, and that a patient's own assessment of their workability and expectation of job success can predict the return to work. There's also DeBauer that found that workability in 195 cancer survivors surveyed at 6 months post-diagnosis strongly predicted return to work at 18 months. And this is after correcting for the influence of age and treatment. As for the attitude towards work, Dorlin says that having high work ethics, negative attitude toward work affected their work functioning, but when there is high work autonomy, that felicitated the work functioning. Maureen?
Moving on to system factors that affect return to work, they can include financial support, wage replacement, legal supports, and the influence of other systems such as medical rehab supports, family, and culture. So from the economic situation, financial point of view, those with lower household incomes were less likely to return to work. Financial strain, lack of financial resources, and upcoming termination of sick leave benefits can result in having to work sooner, but not necessarily coinciding with readiness to return to work. From the medical system, perceptions of the healthcare team about the survivor's ability to work can influence return to work times. Systematic reviews have also shown that timely advice from the medical team, assistance with and use of return to work services, along with a return to work plan and resources can improve cancer survivors' chances of being successful with return to work. In terms of legal supports, having supports within their various systems, countries such as human rights, can support return to work and obtaining accommodations. Some have found that some restrict legal rules around privacy can actually make the return to work process harder. They also found, and this is a Canadian study, that those that were working in a union were less likely to be returning to work compared to the other population. In terms of family support, well, having outside support is found to be a helpful factor in return to work. Overprotective family members or not having their support in the decision to return to work can negatively impact working. Also, it's been found family issues like moving in, family illness, or family being laid off was a barrier to return to work. In terms of cultural influences, one example is a US study that showed that those were Chinese that were less acculturated to the US society and had low income were less likely to be accommodated at work. Next slide. In terms of worksite considerations, that includes work hours, duty pay, job demands, and the demands such as psychological, cognitive, or physical demands, accommodations, support by the employer, and the relationships that exist in the workplace between the survivor, employer, managing colleagues. In terms of worksite hours and pay, worksite factors show that lower rate of return is for those who work in manual jobs, blue-collar jobs, self-employment, working part-time, and that are in high-demand jobs. It is also found that in women in low-income jobs, we're less likely to have accommodating employers. Work accommodations such as scheduling flexibility and gradual rate of return to work were important factors in supporting job retention and return to work. Again, in a breast cancer study, those with accommodating employers were more likely to retain their work. Employers report having stressful work can be difficult for those with mental and physical challenges, which include challenges with cognitive processing, memory, and fatigue. And workplace support is very important, and that includes supervisor and colleagues. With them, such support, they're more likely to foster return to work, but conversely, less favorable work environments can provide more challenges for the cancer survivor who are working. So, Christine? Oh, it's me again. So when you're looking at return to work, you're not only looking at the actual graduated return report, it's important to look at sustained work, and certainly bubbling up in the research as being a challenge. And what we're finding is 90% versus pretty well 77% who had changes in their workstation were more likely to be remained employed 5 years later. And supervisor support over 18 months was associated with increased work functioning. Also, a negative indicator is an increase of quantitative work demands resulted in reduction of work functioning. And lower monitoring, decline in monitoring or less follow-up, and wear off an empathy post-return to work, contributing return to work difficulties over time. Christy.
So looking at a systematic review by Gran-Innes in 2018 has highlighted barriers and facilitators to work participation of cancer survivors, and this is from the perspective of employers and cancer survivors. So as example, they have identified that offering support during the entire duration of the illness was perceived by the employers as a facilitator. And this could be practical, emotional support, such as providing time off work for medical appointment. And also providing genuine support and interest in the well-being for the individuals was also seen as being supportive. As highlighted in this systematic review, to provide support requires an understanding of the employee's capacity, medical condition, treatment and side effect, and their impact on work. It also helps to understand the insurance providers and the physician to have a good understanding of the work situation of the cancer survivor. When looking at the many facilitators expressed by employers for work participation, we see that having a fair understanding to some of these implications, such as also understanding how important to have an open communication is using non-invasive means, such as emails, is also important. But they also say we need to seek the survivor's preference on how they want to be communicated and how often. Employers also recognize that having in place return to work procedures and policies will facilitate work participation, that and also being well staffed, having staff to cross-train either for the cancer survivor or other staff when they take over part of the cancer survivor's workload facilitates work participation. In terms of barriers, employers do realize that avoiding discussing the topic of cancer is a barrier for survivors' work participation. They also recognize that the lack of knowledge and experience with the cancer survivor's medical information can be a barrier, but they also recognize that the lack of support and access to medical specialists is also there that prevents them to further discuss and plan a return to work. Employers also find it difficult to work around the unpredictability of the illness and the absence at work and having to manage the different conditions of returning to work. So perhaps they suggested appointing an independent third party, such as doctors or psychologists, that could be a facilitator. Some of the barriers documented for employers is the difficulty in balancing the interests of the business, the survivor, the colleagues, and even the temporary replacement of the survivor. They recognize the lack of information about also legal options concerning return to work. And there's a CPAC report in 2012 that says that reported on employers' perspective that also arrived at similar conclusion with having the lack of work policies, financial challenges by the organization, and how to obtain timely advice for the employer to properly plan a return to work of the employees were seen as barriers.
So,
to highlight,
go ahead.
To highlight some of the clinical implications of this systematic review by Gran-Innes, the barriers and facilitators highlighted this complexity of giving cancer survivors adequate support. Yet, we know that employers play an essential role for work participation, and to do this, they do require more of an understanding of cancer and its implication, like I said, on work participation. They also suggest to focus on survivors' limitation in relation to work and opportunities for the survivors to participate in work as opposed to sharing the diagnosis. And it was noted that for some survivors, they perceived the employer who updated their colleagues about their sickness as a facilitator, while others perceived that as the employer hindering their work participation. And again, considering that importance and difficulty of the employer-survivor communication, making use of tools for open communication would be an asset. And then being a supportive and empathetic manager was identified as important factors contributing to work participation, and viewing the survivor as normal, not weak, and offering real support in the form of practical and emotional, like I said earlier, such as offering time off for medical appointment. And so finally, not only is a good understanding of the medical implications by the employer necessary for good work participation, so is sharing the legal options and responsibilities of both parties to understand each other's expectations in the return to work process and sustaining work.
Now, we mentioned the Canadian Partnership Against Cancer studies, and they're available on the Cancer Work website under position papers under the research section. Now, they had a series of studies that they did, and one of them was incorporating the views and the recommendations of employers and employer representatives. And their recommendations was first, develop a disability management program to include policy, tools, and corporate culture, and to have this relayed to frontline managers. Again, and related, providing training resources to managers on return to work. They suggested to quicken the pace of communication between physicians and the employer, to provide pre-formatted forms for physicians to complete, and draft return to work plans for physicians to improve. They also suggested developing return to work packages for employees, which include return to work policies. To improve links with their internal expertise, they would recommend that happen, and also learn more about external resources that could be available to provide expertise to that process. They also suggested that in light of the financial hardship that potentially can happen for employers, that there should be some recourse for creating funds for accommodation, and that might include having tax breaks for accommodations and in order to prepare for accommodations. And they also suggested being open to using a broader range of flexible work arrangements, such as working from home. And lastly, basically preparing for it rather than reacting to having somebody with a cancer diagnosis as well as other illnesses and injuries, is setting up contingency plans that include identifying contractors and cross-training employees so that they would be ready to fill in. Next slide. So DUA, which is actually a Canadian study in head and neck cancer, and their recommendations from survivors to employers is to make the application for disability income easier, to honor their privacy but not pity them, provide accommodations that were flexible but also clear, and to be clear about the constraints and the expectations of the employer, to be supportive, positive, and show understanding, have a plan in place on how to deal with cancer in the workplace, understand invisible disability. So some of the comments were, I may look good, but I'm still suffering from cancer-related fatigue. And learn about cancer and its impact, and have a mediator such as a psychologist to help define terms of return to work. Next slide. So related to this, Dr. Mary Kita, who is a part of our group at Cancer and Work and also UT professor, interviewed some 40 stakeholders, cancer survivors, employers, and healthcare providers about effective accommodation and their recommendation for accommodations. And the most commonly suggested was graduated return to work plans, flexible schedules, modification of work duties, altered performance expectations, retraining, support at the workplace, and changes in the physical work environment. She sort of talked about the process important to effective work accommodation was developing knowledge about accommodations, employers' ability to accommodate, negotiating reasonable accommodation, and customizing accommodation and monitoring the accommodation. She reported in the study, she reported that challenges were that survivors had fears about requesting accommodation, developing clear and specific accommodations, jobs that accommodations were difficult to make. It was made worse, a strained relationship before the cancer diagnosis, insufficient or inflexible workplace policies, and employers that were more concerned about productivity or worried that if setting precedent for the cancer survivor for modified duties, and they were elected to do that. Next slide. Additional accommodation ideas that came from the Canadian Partnership Against study was using modified work schedules, flexible arrangements, less hours, work from home, compressed work weeks, and creating modified duty work banks and modified duty programs. Next slide.
So now in this slide, we're looking at the barriers and facilitators from the perspective of cancer survivors on work participation. And this again is from the Systematic Review by Grananis 2018. And what they looked at 47 studies that included cancer survivors' perspective on topics such as support, communication, work environment, discrimination, and perception of workability. And their results highlight that survivors perceive receiving continuous support regularly from the employee as a facilitator, while the lack or no communication was perceived as a barrier. They also see having respectful interaction as facilitating the process, whereas frightening, patronizing, and pressuring communication from employers was perceived as barriers. Discussing the survivor's return to work plan, discussing the limitation and possible work adjustment, and keeping the survivors up to date on changes at work were viewed as facilitating, as well as having a good attitude, a good and long relationship with the survivor and employer, and being able to recognize the survivor's workability and their strengths were viewed as facilitation. For the barriers, when it comes to barriers, they noted that when there's a lack of social, financial, and practical support from the employer, these were barriers. The same for communication when it was negative, frightening, and patronizing and pressuring. Also, having a rigid, non-supportive, competitive, hard-nosed work environment was perceived as barrier. And additionally having a negative attitude, strained relationship, and overestimating the survivor's workability, such as we mentioned, invisible limitation like cancer-related fatigue, was acknowledged as barriers. And finally, from the CPAC report in 2012, they also surveyed the survivors, and they noted barriers as struggling financially and having to come back too early, or having the lack of sick leave to recover, and having to face highly bureaucratic layers of approval. Maureen?
So in doing a study, this was advice from cancer survivors to cancer survivors. So they encouraged them to take responsibility for their health and give themselves time to recover. Let the oncologist advise recovery, not the peers. Be proactive around return to work. Take the steps and ask the questions. Seek support and let people help you. Set reasonable expectations for yourself around return to work plans. Do not depend for the employer to lead the discussion or to return to work and take initiation. Consider disclosure, the pros and cons of the benefits of disclosure. Staying in contact with the workplace. Maintaining positive interaction with those at the workplace while off. Discussing return to work early and often with the healthcare providers, and disclose the need for accommodation. Next slide. So as well, Maheu also talked about one of the challenges with the disclosure is the mixed messages that comes through and the difficulty in determining how much, who, and so concerns of cancer survivors is that they disclosed they would fear loss of long-term prospects such as promotion. Managers were concerned that survivors might share too much and that this could overburden the colleagues. Some cancer survivors or managers were caught in a dilemma of wanting to know information, but also feeling that if they asked too much, they weren't respecting privacy. Some survivors did not feel they wanted to disclose because they wanted to feel normal and leave cancer at home, so to speak, and just sort of focus on returning to work. As well, there were concerns that employers had concerns that survivors may withhold information, have unrealistic expectations, be in denial, and push themselves too hard, not knowing what they need nor feeling comfortable about asking for what they need. And not disclosing to colleagues some information could result on uncertainty and resentment on their part. And in a study of cancer patients that had metastasized cancer, and despite being less productive, they did not feel comfortable enough to ask for the accommodations that they needed. Next slide. So the dilemma around the pros and cons of disclosure is a challenging area, and this is why on the Cancer Work website we created this section, who gets to know how to exercise the power of disclosure. Next slide.
And now in terms of the perspective of the healthcare providers for barriers and facilitators to engage in work participation, Multiple current evidence has found that when healthcare providers discuss survivors' return to work plan, it benefits works participation. D. Moore also found that when healthcare providers provide for a treatment summary, they're more likely to discuss the topic of return to work. And that having good relationship and trust in between professionals from different settings is also helpful in discussing return to work and implementing a program. In terms of barriers, the lack of clarity on the task division for cancer care follow-up, including who initiates the return to work discussion and whose role it is to support the process, are seen as barriers. Healthcare providers view addressing return to work for some as low priority in comparison to treating the cancer. And this can lead to a lack of information also between hospitals and primary care. Also, wanting to discuss return to work until treatment is completed is also viewed as a barrier for successful return to work. In the end, healthcare providers don't always feel confident about advising on work-related questions and say they require more support to enact this role and additional training as well.
Given that the challenge of communication among stakeholders, we wanted to introduce you to some communication tools that are out there. The first three of which are actually on the Cancer Work website. So the first one, the Cognitive Symptoms Checklist at Work. They did a study in terms of people who are back to work. They compared it with neuropsych evaluation, and they found it a pretty good indicator of identifying the challenges that show up in the workplace. We also developed the Cancer Work Return to Work Planner, which is a tool to input the medical information, discuss accommodations, and a return to work plan, including follow-up, not only in the return to work phase, but also over the long term. Also, we created the Cancer Work Job Analysis, which was designed for the employer, ideally, or the cancer survivor, to articulate their job demands in a condensed form to hand that to the oncologist or physician healthcare team in order to be informed about what was expected in their job. And lastly, there's a return to work planning tool that was out there and created at University of Toronto, and it was designed to combined with an occupational therapist to come up with some job accommodation ideas, and if the patient was agreeable, to have this passed on to the employer to guide the return to work process. Next slide. Now we're going to move on to cancer interventions, and they fall into a number of categories. First being guidance from physicians. So some of this could be translating the medical information to the workplace through hospital-based programs. Again, there's the next one is educational information to patients and actually for healthcare providers to educate on the return to work process. The other one is actually providing counseling rehab support. Another approach is case management, where somebody is following a patient, but guiding them along by phone in terms of the return to work process. And Christine's going to talk to you about a Cochrane review that discuss kind of the review of efficacy and a rigor of research studies. Next.
So this is the Cochrane review by DeBoer 2015 that evaluated the effectiveness and the rigor of 15 studies that compare people who did get an intervention in randomized clinical trials, so RCT, versus those who didn't, and then how randomized clinical trials could enhance the return to work of cancer patients and the quality of life. So in this review, they had 15 RCTs, 4 types of different intervention identified, and most studies was with breast cancer patients for a total of over 1,800 patients analyzed. And their main findings was that 2 psychoeducational intervention versus the usual care did result in a higher return to work rate. In fact, they were similar and there was no difference on the quality of life. There was 1 intervention that provided physical training, and this was no more effective than usual care. Among the 7 RCTs looking at individuals who received medical function conserving therapy, such as lumpectomy versus more radical treatment like mastectomy, again, they found that the return to work rate was similar with no difference with quality of life. And among the 5 randomized clinical trials involving a multidisciplinary approach, such as vocational counseling, physical, psychoeducational, They found higher return to work rate, but no difference on quality of life. And in this Cochrane review, not surprisingly for us, they did not find any specific intervention for vocational rehab. So in conclusion to this Cochrane review, they found moderate quality evidence that a multidisciplinary intervention can enhance the return to work of patients with cancer. However, they recommend further testing of this approach in population other than breast, such as with colorectal or lymphoma. As well, they recommend that the vocational component should be not just be patient-oriented, but should be also directed at the work environment and include work adjustment and include the involvement of supervisors. This is another systematic review by Fong for another looking at interventions that focus on examining the psychosocial interventions with intervention components looking at changes of behavior, psychological, education, and vocational content aimed to facilitate the cancer survivor's employment outcome. And these included employment status, their return to work, absenteeism, and time spent on work disability or sick leave. They found 12 studies, eight which were randomized clinical trials, and the other quasi-experimental, pulled from 7 countries and compiled results over 2,000 patients, excuse me. And the results show that when cancer survivors take part in any of these interventions to support the return process, they were more likely to be employed or have higher return to work rate in comparison to baseline compare group for a difference of 68 versus 60%. And this difference was significant. But there was no difference for time spent on work disability or sick leave for those who took part in an intervention. But their conclusion was that the support provided in the intervention varied, as shown in the graph, and only 2 interventions directly addressed return to work plans combined with informational sessions. Yet these combined results are significant for any of the intervention. But the authors do caution that many of these RCTs had higher risk bias, which means weren't that rigorous or had bias that we could make a judgment on the outcome of the results. And they do recommend additional rigorous studies to be done before we go ahead and recommend this approach in practice.
So looking at exercise studies that didn't seem to make the Cochrane review, some interesting results in terms of hours of work. So the CITA study that found, which is basically providing a hospital exercise program, well, it didn't change the actually return to work date time, our hours. It was 11.5 weeks for the non-intervention group versus the intervention group. They did find that those that participated in the study had less reduction of hours, 5 compared to 11 hours. And on long-term follow-up, 78 of those that were in the intervention study versus 66 returned to pre-diagnosis working hours. Also, on another study looking at occupational physician advice and a return to work and an exercise program, they didn't see not much difference in terms of productivity, but they did see that those in the intervention group were working 5.8 hours more a week per year. Next study. So moving on to intervention studies that have come out since the DeBoer analysis. The first is a German study, and they basically, their usual care, which shows what's available in some countries versus others. In Germany, they have sort of mandated inpatient rehab. So usual care is exercise, physiotherapy, occupational therapy, psychological, nutritional counseling support, versus the addition of work-related functional capacity training. They did not find any differences in role functioning, but the participants reported better ability to cope with pain and fatigue. I'll have to say, in terms of the tool that used to measure, in terms of role functioning, and it's not surprising you'd see the similar, because role functioning, when you use that measure, asks whether your ability to work and work at things like home has improved or has changed the same or got worse. So I'm not surprised that it would come out the same, because they weren't specifically measuring return to work. Another study looked at health coaching and occupational rehab, and this involved 6 to 8 coaching sessions, physical, psychological, social, general well-being. And this is from Australia. Again, standard care in Australia is actually to provide rehabilitation and vocational supports. So they didn't find too much change in terms of return to work outcomes, but the patients did talk about how they appreciated the intervention. And in the US, they have one of the few industry sort of led studies done on Johns Hopkins University. They had a nurse navigator, and the nurse navigator would coach the patient and also provide a referral to a website. The website was mostly talking about return to work policies. What was good about this is the nurse had access to oncologists that were experts in and could provide sort of medical information. But they didn't see, there was a low uptake, like not many people participated, no difference in self-efficacy, but the patients did appreciate the non-judgmental approach of the nurse in terms of who's following them. So next slide. So in another study looking at a hospital-based program where they would have a nurse and a social worker providing follow-up, a letter from a treating physician, an occupational physician meeting between the occupational physician, survivor, and employer to develop a return to work plan. They found no difference between the groups in resumption of full hours or quality of life, but admittedly, the researchers admitted that actually they did wonder if this was because the hospitals that participated in the research were already motivated and speaking about return to work in their population. But they did find that people that participated in the group had better numbers than the rest of the population in comparison. Another study looked at occupational physician integrated into the healthcare team, so becoming an oncology occupational physician. They found the satisfaction was very high because they had knowledge of cancer and work related problems. And patients also felt they appreciated their independence. I believe it's in Britain or Scotland that they've instituted a self-guided work book where they have cancer survivors go through exercises and a particular focus on goal-focused education related to work. They found 30% of the controls versus 43 of the intervention groups, so 43% returned to work compared to the controls, and the numbers were even better at the 12-month stage. And again, with developing the cancer and work, we have, after integrating the preferences for information on the website, we have since asked for evaluation of satisfaction, and 60 viewers have sort of noted that they find the website has been helpful and it's important to them. Next slide. While this is not an intervention per se, it's program evaluation, I did find it interesting because these were state vocational services offered in the US. And at the time, the participants were not employed or at risk of losing their job. And they found with intervention, 58% were able to maintain or obtain employment. And they found the interventions that were particularly helpful were vocational counseling, miscellaneous training, rehab technology, job placement, job search assistance, maintenance services to increase the odds of employment. And those who were successful, they also found that those who were more successful had more services but spend less time in services. They did a follow-up study to determine what group, the unemployed group versus those who were returning to their former workplace, what services they received. They found the employed group received diagnostic and treatment services, rehab technology, and job accommodation, while the unemployed group received vocational training, job search, and job placement. Next slide.
So now looking at the Joyner-Briggs evidence summary by Whitehorn and other evidence from other studies, we reviewed the role of the general practitioners in work-related concerns about the return to work in cancer patients. And it was found that treating physicians do not always feel confident about advising on work-related questions, and that general practitioners or GP also consider that the specialist cancer nurse to be the best healthcare professionals to discuss the return to work due to her frequent contact with the patients. However, it was noted that the nurses believe it was the reverse, that it was preferable to have the GP provide this advice. Barriers identified by the GP to provide return to work support were feeling like they do not know enough about the cancer survivor's job role to provide return to work advice. And some GP believed that providing return to work advice was outside of their scope of practice and beyond their expertise. We can say that healthcare professionals have no consensus on whose role it is to initiate and communicate with cancer survivors on the return to work process. There was also another study suggested that occupational therapists, so OT, should be considered the most appropriate healthcare practitioner, although they were concerned about their availability and the cost of these professionals. But patients have mentioned that they appreciate the oncology occupational health physician role, and they are seen as being more independent than the workplace occupational health individual, and can provide for greater awareness of work and provide consistent advice among the team.
Well, there's no consensus in terms of standard practice in terms of rehab teams. I wanted to introduce you to a few studies out there. One is Silver, for example, discusses the roles that multidisciplinary members could provide cancer survivors with supporting return to work. And as well, what we're seeing in the research is a lot of occupational therapists talking about studies about how helpful they could be given their experience in terms of supporting return to work, but actually no studies in terms of looking at that. And Desiree in here talks about 5 ways occupational therapists could support the structure. Now, realizing that many people may not know the opportunities for roles in terms of supporting return to work, in the Cancer Work website, we actually, under Roles Professional, talk about how different roles can, various stakeholders can to play in terms of, and what they could do in terms of supporting return to work. So overall recommendations that I was sort of gleaning, and Christy and I were gleaning from the research, is there's the need for screening, and using something like a vocational rehab model, screen early and often, and if indicated, intervene. There needs to be improvement in assessment, improving access to information and work function for the healthcare provider, survivor, and the employers by having tools, training, and access to experts. We need to guide, increase experts and subsequent advice to healthcare providers, employers, survivors, and how specific cancer and treatments might impact work, and provide suggestions on how to improve workability. And there is the need to foster a supportive work environment by encouraging continued positive communication between the employer, colleague, and cancer survivor. And to support sustained employment, there needs to consider accommodations and financial support for systems to allow a person to work to their full capacity and over time. And again, I think the theme is also creating multidisciplinary teams that are work focused, that include expertise. And I think in particular, occupational and vocational rehab could certainly support these teams in terms of promoting return to work. Next slide.
And so before we finish, this slide is about for the Canadian Cancer and Work website, and we're seeking your interest to take part in the study that we're currently doing, where we would like to assess the usability of this website and the utility and the satisfaction of the resources and the tools. So we have currently we have over 800 people that are visiting our website per week to get support for the return to work process, and these come from cancer survivors, healthcare professionals, and employers. So it's a very but with some of the feedback we receive is that although we have lots of information, over 500 pages, they also find it very comprehensive and dense, and so we want to improve the content and the usability to make it more user-friendly. So in this aspect, we could really use your help to make the website more helpful and usable. And so we would invite you all, if you can, to participate in this coming study that we have. And if you're interested to take part or to provide some time, please contact me at my email, christinemaheu@mcgill.ca. So we would like to thank you, Maureen.
Yeah, I just wanted to add to Christy. We have a lot of viewers. Christy was mentioning 800 viewers per week of people, and we would very much appreciate your input about how we can improve the website and increase the utility.
So we would like to thank you for your attention and for being online, and we would like to open it up to the question period.
Thank you so much, Christine and Maureen. The excellent presentation, and immediately we'll start our Q&A session. So the first question goes back to the beginning of your presentation, and is how would you explain that cancer survivors pertaining to a union are less likely to return to work?
Well, you know, and this is one of the challenges. Is a Mansell study. It was Canadian, actually. This is a bit of a challenge of having quantitative versus qualitative studies. So this was very much asking kind of the facts, not so much why. But I would hypothesize that possibly a union is more blue collar jobs and manual jobs in terms of union environment. And we certainly see in terms of that's a negative indicator. It's harder for people that have physically demanding jobs to go back to their job. And also maybe there's also the support. Maybe there's a disincentive in terms of financial support, but I also think it might easily be that they might be more physically demanding jobs.
Makes sense. Are there any companies or organizations that have implemented effective plans or models contributing to the success of return to work for cancer survivors?
No, I think that's one of the challenges, is that there's very industry. There's very, if any, the one study I think I quoted, but there hasn't been a lot of research in the employment at the workplace end. And I think that's what they're sort of crying out for, that we need to be looking at that.
And if I can add to that, Maureen, a few months ago, I visited the National Cancer Institute in Paris to discuss our website, Cancer and Work, and they shared with me that they had a list of enterprise that actually has signed an agreement to provide to develop and provide return to work policies for cancer survivors, and they had over 46 employers who signed this list. So interesting. So I'm looking forward to see how they went about doing this. So to see if we can replicate for here in Canada.
And certainly one of the things is we have in our website a research section, and we hope to sort of build that. So when we see things like that are up and coming, we'll be posting on the website, so you're aware of it.
Thank you, Christine and Maureen. Next question is, you mentioned that coming back to work too early is a barrier to return to work. So in your opinion, how can we measure that, and who is in the best position to make this decision?
I think, and again, I'm as a vocational rehab counselor. I think it's a combination of a few things. It's a combination of patients knowing themselves. Like, again, I think what was also in the research is they need to be realistic. I think in some cases, they talk about the need for financial support, so people aren't coming back too early based on financial need. But I also think in more complicated cases, and I think particularly like cognitive challenges, that you may need the expertise of something like an occupational therapist, a neuropsychologist, in terms of helping assess that. And what I'd personally like to see, and I certainly encourage our healthcare team to encourage insurance providers, is to provide such assessments that are really connected to the workplace, like worksite assessments in terms of workability. Because I think one of the challenges with assessment is it's pretty abstract, and even if you're having a neuropsych assessment or a OST assessment in the hospital, it's still not reflecting the work environment. So I think assessments that are very work focused and that even at the workplace might also be very helpful by experts such as occupational therapists.
And just to add a little bit as well, what happens sometimes is that when they return too early, the individual may feel well and feel strong, but once they're back at work, that's when they're confronted with some of their late effects that happens a bit later down the road, such as cancer-related fatigue. So it may not happen right away after treatment, but suddenly 1 month into their work environment, they start experiencing cancer-related fatigue or cognitive challenges. And so that makes it more of a struggle to sustain the work. And like Maureen said, we offer on the website, we have some tools such as the cognitive checklist at work that the individual can complete to see if they are, at least it's a screening tool to see if they are experiencing work-related challenges with cognition. And then if they are, then they can bring this tool to their healthcare provider and discuss it. So sometimes that's in the context of where somebody may mention, I returned too early, but only once at the work site that they recognize some of these challenges or limitations they're experiencing from the late effects of cancer and its treatment.
I think I've seen in some research studies that we should be looking at risk factor groups, and what they've talked about is who, self-assessment is often very helpful. Sometimes you need professional assessment, and so they're starting to work towards that. And we're getting bubbling up and talking about it in the intervention studies of deciding who needs more, and in terms of intervention and in fact in terms of assessment.
Perfect. Thank you so much. In the Cochrane study, you've mentioned 4 interventions. So what kind of interventions were involved in order to evaluate whether they enhance the return to work of patients with cancer?
So in those, they were talking about just general psychoeducational intervention, and this is anything from providing either face-to-face support or just a pamphlet. And some had physical training or not, but then the downside to these physical training is that they weren't work focused, meaning they weren't, they had physical training, but it wasn't geared towards what they actually had to do at the work site.
Perfect, thank you. And then we have another question. So in relation to the grant Cancer and Work just received, one of our audience member is asking if they would be it would be translated in other languages, for example, Spanish.
Oh, wouldn't that be great? So currently the website. So, there's always that competition and struggle to get more funds. We would love to, if we can somehow get funds, additional funds, we would love to translate in other languages. We're also looking into, with these funds, to see if we can use like Google Translate to translate some, like automatically translate sections of the website. But currently we have manually translated 80% of the website into French, and we had to pay a lot more for that. So not all of our tools are translated, but we're working towards that. But right now we don't have any like government support. It's mostly Maureen and I trying to go here and there, trying either private financial support or grant support from agencies. But if they have ideas, we welcome them if of places we can apply and get this into Spanish or other languages.
But I think it speaks to the comment that most of the website, it would be helpful to people across the globe, with the exception of the resources, the financial resources, and the legislative stuff. But everything else sort of mirrors kind of what the research is showing in good practice in terms of disability management and voc rehab.
Perfect. And this member of our audience is actually very interested in participating, and I'll put you in touch maybe after the webinar if you'd like.
They can all contact us. Great.
For sure.
Thank you.
Okay, and then maybe a last question. You have mentioned that physicians as well as specialist cancer nurses do not feel competent to advise cancer survivors on work. Do you have any ideas on ways that can be used to help them overcome that?
Yeah. And I think the thing is, I think we need to add expertise in occupational therapy and vocational rehab into oncology teams. Because I think with that, they would have, if they're unsure, they have an occupational therapist that can assess somebody. And I also think they need more training. Again, something like the job analysis informs the physician of the requirements. And again, I think, and it's sort of saying more training. The oncologists in particular are not trained to be occupational physicians. Or I would also argue that maybe there needs to be more a role for things like survivorship programs where, and I'd like to see more research in terms of looking at function in particular to return to work, where it could even be a nurse practitioner-led survivorship program where they're tracking and following and becoming expertise in this. Because one of the comments we're getting from particularly oncologists is they're busy, and their focus is to treat cancer, and they don't always have the time to address the work stuff. And so, where the big issue here is, where do you put the training so we can support these physicians to provide the right guidance?
And Maureen, perhaps you can talk about our video from the lawyer on our website that creates the
guide. So, and it came at the request of physician, particularly related to filling out insurance forms. We ended up having a lawyer come in and talk about how to fill out an insurance form. And it was great because she should have talked about how to speak in terms of function. in order to sort of relay return to work readiness to insurance providers.
And she was speaking for a physician, and this video is available on our website.
Perfect. Thank you so very much, Christine and Maureen, for sharing valuable evidence-based recommendations for the return to work of cancer survivors. You have mentioned the importance of employer support, a more active role played by healthcare providers, additionally to steps on return to work programs that cancer survivors can address. So thank you very much for your time and your tremendous efforts toward changing work environments into better places for cancer survivors. Turning back to our audience, we appreciate your attention.